we're going to talk a little bit about sort of implant processes, auditing, how we go through the bits and bobs, I think, in this module. Okay. One of the things that we need to do is need to sort of track and follow the patient journey as that goes through, and some of the documents that we use or what we use in terms of tracking how we can monitor that patient, how they come in and how they go through that implant process all the way up to, you know, hopefully restoration and maintenance, because sometimes we're not the restoring clinicians, but that follow-up. So once the implant's been seated, restoration been placed, and what happens after that for our patients. And there's a workflow that we follow with that, and there's some sort of documentation that we use. But obviously this is your area of expertise, although, you know, I do obviously have a look and see where things go. But let's talk about what happens when we get that initial referral, which might come in the form of a self-referral. Patient might contact the practice for an email or a phone call, make an inquiry, or they may have been referred from a colleague, a dentist, or they might be a returning patient. What happens with that process once that patient's made contact?
So in virtually all our practices, we have a TCO, so a treatment coordinator. So in the first instance, they normally touch base with a patient, and an initial appointment can be made with a TCO, and that is offered in the way of a free consultation. So obviously it's non-clinical, and this can also be done online, face-to-face, like we've just said, or over the phone. And that appointment is an information gathering appointment with the TCO or head nurse. It doesn't have to be somebody clinical, because as I said, it's a non-clinical appointment, and they will triage the patient for us. So they will ascertain what they are referring for. So if it is a self-referral, we're looking to see if there's a missing tooth, a failing tooth, if it's more than one tooth. This would be the same if it was a referral made from a clinician to us, and that might come in paper form, it might come by email, but the information is the same. What we do get in addition, if it is from a clinician, is we're often lucky enough to have a radiograph and x-ray as well, which is fantastic. So that would be the first thing that happens. So to land that patient in the appointment book, they would have an appointment with a TCO or a phone call, appointments booked, and information's gathered and it's shared with us.
In terms of how that information is kind of shared with us, that comes through as sometimes it might be a document. But in terms of the practice, what do they do to sort of put that information down? Spreadsheet, simple spreadsheet?
So we have processes in place that we put through all the practices, and it's something that we would actively encourage any TCO, a dental implant nurse, receptionist, anything. If you have that tracker, you can put pretty much what you want on there, but that will act as your Bible, really, as you're taking that patient through their patient's journey. So on that document, you would have obviously the obvious details, which would be the patient's details such as name and date of birth, email address, contact details, what they've referred for, who they've come from, so whether it's self-referral or a clinician. And then going back to that appointment that the TCO would have had, obviously they would talk through the implant process, because it won't be bespoke, obviously, but you can talk in generic terms. So you can talk, we have fixed fees, so you can talk about fixed fees without obviously giving a quote because they haven't been seen clinically. But any information in and around surrounding the implant process can also be discussed at that appointment.
So in other words, what we've got is this triage process. And then we've gone through that process. Patients essentially funnel sort of down. They understand some of the bits and bobs that are going to be discussed. And then there's that actual consultation, the face-to-face consultation, which when we have that, there's a certain set criteria that we go through, and the clinician will sort of listen to the wants and needs of the patient. They already have that, hopefully, but that might not always be the case. So it's very careful we understand what it is the patient's looking for. And then the obvious, the medical history, social history, you know, the backgrounds, all that, then checking a clinical examination. And that might result in further tests being required. The intraoral scan is usually taken, if not, it's been taken already, which is the equivalent of the impressions for StudyCast diagnostic needs. So that can get sent to the lab and a diagnostic work through can be made, sort of understanding where, because we always work from a prosthetic way to place the implant. So in other words, we look at what's going to be placed on the patient in terms of a tooth, a bridge, full arch bridge, or dentures, and then that guides where the implants are going to go. And that's the way the workflow always works. So that's the need for the digital scan or the impressions. And then radiographs are taken, and CBCT may be required because the patient might not be ready. Teeth might need to be extracting. So then it starts to filter down a little bit. And then what we need to track is that workflow of where the patient's gone. They might need periodontal treatment, they might need endodontic treatment, they might need extractions. So there's various other factors that need to come in before we consider placing implants, because we want to place an implant into essentially a stable mouth. So they might go through, and then it's how do we track that patient? How do we track that patient's pathway? Is it similar? We do spreadsheets again.
So yeah, it would be exactly the same. It would be on that tracker document that we've mentioned. And as you've said, some patients might need an extraction. They might need to go and have some perio done. Therefore, they might not have had a CBCT, but they will need one. That document, that tracker, does exactly what it says. It will track that patient. So at any one time, that can be picked up and they can see where patient A is and what patient A needs next after they've had an extraction or after they've had some perio work. So that document, albeit small, is very powerful and really, really useful.
Yeah. And one of the things then is we've sort of come to the consent forms and the treatment plan, and things then need to be checked and ordered. So there needs to be some kind of checking that everything is in stock, that all the gowns are in stock, the gloves are in stock, the antibiotics are in stock, and then ordering the implants. We might need to order several implants, not just because we're placing several implants, but what's always good in the start of the journey is for the clinicians to order the implant that they think they're going to use, and then order implants around that size. So they might want let's say a 4 diameter implant, they might order a 3.5, and they might order a 4.5 implant diameter around that, and they might order 8 millimeters and 10 millimeters. So they've got a few implants around the area, just because although they've planned to use that particular size implant, they might alter it. Things need to be provided. So stents, guides, fully guided if you're going down that road. So there's things that need to be ordered and checked that they are in stock and ready for that patient. And then there's a certain process we have prior to that patient coming in for that surgical appointment. So we're assuming now that the patient's stable, they're going to go ahead with the implant surgery. An appointment's been booked. That's in the book. Is there anything that happens prior to that actual appointment at all?
With the patient, normally they would get a courtesy phone call prior to their appointment, just to check if they have any questions, reminders to bring any bits and pieces in, if they're bringing any additional medication information. Obviously, we would want that beforehand, but it's just a reminder from the consultation to the day we place the implant, whether anything's changed, so they can update the implantologist. So normally it's a confirmation phone call, but it also can be just to make sure that medical history is up to date.
Yeah, and those phone calls vary again, but really that confirmation phone call is a couple of weeks before the surgery, and then 24 hours before the surgery appointment, usually, from our experience. Would you agree?
Yeah, absolutely. Absolutely. And obviously, a couple of weeks prior to the appointment, your TCO should be checking that everything's there paper-wise as well. So the consent's been sent out. We need to check that it's been, the TCO needs to check that it's been signed and returned to the practice as well. So don't do that the day before. Definitely a couple
Yeah, I
of
think
weeks
it's important
before.
that you have that leeway. That consenting the patient on the day isn't, in regards to the GDC, I think, or anybody really, is true consent. There have been times where I've experienced some medical procedures and they've consented me 2 hours before the general anaesthetic, which was fine by me, but I don't think that would hold up against the GDC in real time. But anyway, we digress a little bit. So we know that we've got that. All the process has been followed. Everything, all these little sort of tick boxes, which are important so we can follow that workflow, are done. Then it comes to the day of surgery. The implants have been placed, and one of the things that's on the implants is a reference on a lot number. And that's the same with any materials that we've used, which again should have been ordered, such as membrane and bone. So we'll record the lot number in the notes, but also as clinicians, there should be a logbook that they're following. And then some clinicians will have a portfolio. I still keep a portfolio even after the amount of implants that I've placed. So we'll have that logbook. It's an easy reference. You can reference back to the implants. That reference number is unique to the implant manufacturers, and that lot number is sort of accountability, really. If anything goes wrong, it's a traceability, just to make sure that everything's okay. And that helps, again, the companies, I think, just track as well. If anything did go wrong with those implants, some companies will take the implant back. For instance, if there's not integration, and have a little look and analyze it, which may be or may not be of some use, but it is really then easy to follow what's being placed on that patient, and it's good housekeeping. It's good housekeeping. Then after that, we've got the post-surgical follow-up, and there are various ways of doing that. But what's our gold standard for follow-up from the patient?
So again, if we're saying TCOs, they would be contacting the patient, if not the day after that, to give them a courtesy phone call and check in and check that they're all right. What they would also do, if it hasn't already been done, is start looking at the follow-up appointments, see what appointments need to be made if they haven't already been done.
Yeah, great. And there might be various things that we need to have a little look at. So the patient might be coming back in again for a suture removal, review of things, and then there are appointments that are made, and they vary depending on the times. So we might be seeing a patient sort of 6, 8, 12, or longer, depending on what the procedure is. And again, that's tracked and recorded. And then the patient's coming in, and then they might be then for either a provisional restoration or the permanent restoration. So there's what we call indexing, which is the same as taking impressions for crowns or scanning for crowns. And that's where we're recording the position of the implant in relation to the teeth and the soft tissues. And then that will get sent off to the lab. So there's another tracking process that we're looking at: what's been sent to the lab, which lab has it been sent to, what's the patient sort of, what are we looking for, what's the prescription to the lab shade, all those other little factors, the materials. Usually when it's digital, that's logged onto the digital side, but it's always a good idea just to put that into the notes as well, so that that prescription will sort of follow that patient around in the notes and on the scan. But you can do that written down and scan that into the notes as well. So there's another record that we're keeping. And then a separate audit of this. So we're auditing this process, and that's done periodically, every 6 months or so. Just auditing the success of the implants, making sure that we're getting that high success rate. If there's anything that's happening, we can identify and modify again. Things like patient satisfaction surveys, lab work, how that's being followed up. But we can talk about that in another module. And then we've got then the fit appointment. So there's a certain criteria or a certain recommendation that we suggest. I'll pass over to you.
What I was going to add in as well, obviously from the placement appointments, if you have patients that have been referred in and they haven't self-referred, is obviously keeping the communication going with the referring clinician as well, and especially if you've got the relationship and they're going to be restoring on the implant, because that effectively could be one of the last times you see the patient. Obviously, I would imagine you'd be reviewing the implant and then it would go off to the restoring clinician. So it's really important that communication is kept with that referring clinician. They're also going to need to know the implant details, because obviously they're restoring on them. And again, coming to the fit, when you finish completion for that patient, it's courtesy to send a completion letter out to that referring clinician as well, passing them back into their care. Sorry, Carl.
You don't need to apologise. It's something that I omitted when we were talking about it, but I think that's correct. I think that's a gold standard. Referral's been received. A letter that the referral's been received is sent out. If it's been a referral, that might be a non-restoring or restoring clinician. And then a letter pretty similar to the one that goes to the patient, outlining the findings of the consultation, and then might be some follow-up. So it might be that they're extracting the teeth, making a denture. There might be some periodontal disease that needs treating. All those little things are going out back to the clinician, usually if the clinician wants to do it, unless the clinician asked the practice to do it or ourselves to do it. So that's sort of that communication that's toing and froing. And again, I agree. I think it's good for them to know when the patient's coming in and when that surgical appointment is, just to keep them in the loop. I think it's nice if you've got someone you're referring in. And then again, I totally agree that final appointment, when that implant's been fitted, understanding what that implant was, all the notes that we talked about, what company it was, Ad Straumann, Ostem, write it all down, the reference number, the size of the implant. So all these records are sort of following that patient around. It's good, robust note keeping, auditing again. And then again, that final appointment, reporting back to the clinician that the implant is integrated, how the patient's been, and thanking them. And then again, reporting that detail down.
Absolutely. And also the following that through with all the letters that we're talking about that are being sent out to the referring clinician and to the patient in the form of consent. That is important to record on that tracker that we're talking about as well, so that you can see if the patient's had the treatment plan, if the letter's gone out to the referring clinician, and then if the referring clinician's been given the letter about, or email, whatever is their preference. So you've got to track all of that as well, so you know that those things are being done. It's a really good tool, the tracker.
Yeah, I think it is. Again, there are forms that can be created or that are available that you can jot down a lot of these things. Very simple to do, very simple to follow. I think that about wraps it up. Unless you've got anything else that you wanted to add on this sort of journey.
No,
Excellent.
thank you.
Thank you very much.
Thank you.